Senthil will talk, akan bicara tentang the role of myofascial chain in manual manipulative therapy. This is really important and relatively new, especially for me. So please, Professor Senthil, and after 5 minutes, Professor Imam, saya mohon bantuannya. Oke, Professor Senthil, over to you. Time is now, Prof.
Right, Professor Asyad, Professor Waluyo, and greetings to Professor Khanna. And of course, I take my opportunity to welcome the President of AOMPT, Ritu Sani ma'am. So Madam is the President. It's good to have her presence for this session. Role of myofascial chains. Myofascial chains in manual and manipulative therapy.
Welcome, Madam Ritu Sani. Welcome to this event. Really, thank you so much. Thank you so much, Professor. Thank you so much, Professor Senthil, for bringing Professor Ritu Sani in this event. Go ahead, Professor. Go ahead, Professor Senthil.
Yes, sir.
Thank you so much for your warm welcome. Yes, and on behalf of AOMPT, we all are blessed with the best academy and as well as the best mentor, which all the topics we are learning from last 2.5 years. For that, today that sir is going to showing you that myofascial chain. That is very important topic because whenever the musculoskeletal disorders or the patient is having a muscles problem or related to the neural problem, the myokinetic chain plays a very major role for influencing one part to another region. So this is a very important topic. So we all will learn together, as we are already associated with the Indonesian team and the UMPT team. Both are together because last year also, I think the same day we have some myofascial topics sir has covered. So all are welcome in the UMPT, and you can all upgrade yourself with the UMPT courses. So thank you so much, and thank you, sir. Yes, sir. Over to you, sir.
Yeah. Thank you so much, Professor Madam Ritu Sani. Yeah, Professor Senthil was really excellent. I have been two times become his moderator is really excellent. He is really excellent. I love everything, not only talking but showing also. So yeah, thank you so much, Professor. We are really grateful and honored. We have Professor Senthil working with Indonesian physiotherapy and other healthcare professional in Indonesia. Okay, Professor Senthil, go ahead, and Professor Imam, please follow up. I will leave for a moment. Thank you.
Okay, sir. Professor Asyad, sir, and also Ritu ma'am's best wishes for the participants. We are always indebted. Most importantly, I want you to see what is in my hand. So I have a green color band that is attached to an yellow color band, again which is attached to the black color band, and that is attached to the red color band, and lastly we have the blue. So we have around 5 colors of bands which are attached to each other. The same can be plantar fascia. The green is the plantar fascia, the fascia in the sole of the foot, and then the yellow can be the gastrosoleus muscle, the calf muscle, and next the black, it can be the hamstring muscles, which are posterior part of the thigh, hamstrings. And then the next one, as we go higher, the red one is the gerakan spinae. And then the last blue one, we can see for the suboccipital muscles. Allow me to just relocate the fan. Fitri, she's alerting me that I should switch it off. Yes. So I'll move this model so that you can see the posterior side, the back side of the model. So how do we go about is a connection, a chain, a relationship, right from bottom to the top, from head to the foot or foot to the head. The plantar fascia in green, the calf muscle, the gastrosoleus in yellow, the hamstrings in black, red is for erector spinae, and this blue is for the suboccipital muscles. And you also have the fascia of the scalp that is called as gallia aponeurotica, the Latin name. This is a best example of the superficial back line. Back, it's in the back. Line, because it's a line of muscles. It is superficial because it is the first layer. Of course, above that superficial line, which is depicted in yellow, we have a purple tape, which is crossing from the left shoulder to the right hip and left hip to the right shoulder. Hope you are able to pick it up. Okay, that which is crossing like this. This is the functional back line. Why it's functional is because latissimus dorsi of the scapula or the humerus, it gets connected to the thoracolumbar fascia and then it gets attached to the gluteus maximus, which is again attached to the iliotibial band, the greater trochanter. So in the back, we have two layers. One is the functional back line, which is important. Why for functional? We were saying about the sports, and Professor Khanna was highlighting that soft tissue techniques are important. Imagine a javelin throw, a shot put, person who is doing a volleyball or doing a basketball with one hand. Whenever you do with your right hand, always you will notice that you just not only use the hand. What you do is keep the left foot, and then generate the force from the left foot to the right upper limb. So that means the force is generated from opposite side lower limb, and then it gets transferred via the gluteus maximus, thoracolumbar fascia, latissimus dorsi to the upper limb. In risk factors for sports injuries and also in individuals who have calf muscle tightness, so I have a tight calf muscle on the left side. I am at risk for developing shoulder impingement syndrome, shoulder pain at the end range of the movement. And it also reduces my sports performance because I am apprehensive. I get the pain. Why? Because the opposite side calf muscles are tight. So it's a combination of the superficial back line and also the functional line, where calf muscle tightness can lead to the internal rotation of the opposite side upper limb. And you know, internal rotation, if you internally rotate the arm, you cannot elevate. You can only elevate when you externally rotate, you will get the full range. If you do internal rotation, thumb is facing backwards, you will get only 80 degrees. So reason for impingement in shoulder, because internal rotation. And internal rotation, latissimus dorsi. Why latissimus dorsi is overactive? Because through the thoracolumbar fascia, gluteus maximus is weak, opposite side. Why gluteus maximus is weak? Because gastrocnemius is again tight or overactive. So this kind of an interrelationship is what we call it as myofascial chain. You may be asking, is it only the back muscles that are working? We generate from the foot and we are using the upper limb. Is it not that front muscles, they are not working? That is why we have two more chains which are also important. Especially when you stand on one leg, you lift your right leg. I'm standing only on the left. Means my left side, all the muscles has to maintain my balance. Because right leg is lifted up. Okay. If I have to show my leg, you can see I have lifted my right leg. So all the muscles on the left side are working. And that muscles which are part of the lateral line. To see the lateral line in the model, it is the orange tape which is applied right from the foot lateral portion, which includes the what is called as the abductor digiti minimi. Okay, lateral part. Peronei, the peroneus longus brevis. And then the iliotibial band. Then we have the tensor fascia lata. The tensor fascia lata, which is important for holding the iliotibial band. Together with the gluteus maximus, but primarily you see that it's a lateral force, which is a balance between gluteus maximus and the tensor fascia lata. Then you have in the lateral side of the trunk, the quadratus lumborum. The quadratus lumborum muscle from the 12th rib to the iliac crest. So that is the lateral flexor of the trunk. And also we have two muscles, one which is directed like this and the other which is directed opposite to that, the fingers, fiber direction. Those are the internal and the external oblique. They both are rotators of the trunk. So when you rotate, they work. They are part of the lateral chain. And then we have the intercostal muscles between the ribs, which is important when we do the side bending to separate the ribs and also expand the lungs and also to transmit the force from the abdominal muscles to the neck muscles. In the neck, more proximally, you can see that it is the posterior fibers of the sternocleidomastoid and the splenius cervicis muscle. So they are there in the lateral side of the neck, depicted fully in the orange tape for the lateral line. The lateral line is important for people who have leg length discrepancy. You have one leg short. So what do? You have a tendency to bend towards the right leg. Because my right leg is short, I will bend like this. Right? So this kind of a lateral deviation or force that we generate when we walk sideways. We walk sideways. That is the lateral line of the trunk. So it's always important to understand the role of various lines. Unilateral activity, one leg or one arm. It will definitely include the lateral chains of the lower limb and the upper limb on opposite side. So if I'm using my arm up on the right side, right proximal lateral line, proximal, that is above the iliac crest, and left distal lateral line will be working more than the other partner reciprocally. So we need to understand that it's not just one muscle which is working for throwing. You can't say that it is only the supraspinatus tendinitis. I will treat the supraspinatus. Or I find latissimus dorsi tightness, I will do the stretching of latissimus dorsi. Unless you evaluate the chain and you find that calf muscle on the opposite side is tight, if you don't treat the calf muscle, the athlete will never regain the full performance of a functional achievement or record-breaking throw. So understand the role of the chains. Physical therapists need to know these myofascial chains. In AOMPT, we classify myofascial chains into 3 types. One that is anatomical. The muscles which are developed together embryologically. So they are just formed together. Because remember, in the human body, fascia is formed first. Later only muscles are getting differentiated. So muscles are younger than the fascia. So fascia forms the compartment and muscle buds, the myoderms, form within the facial compartments. So it's important for us to understand the role of fascia and muscle together. And some muscles which are developed together, they always try to work at the same intensity. So if one is overactive, other also will be overactive, other also will be overactive. All 3 will be overactive. So in the same example, which I was showing you the chain, if the green is overactive, black also will be overactive and blue also will be overactive. So it means that plantar fascia tightness will accompany a hamstring tightness with suboccipital muscle tightness. Patient may have heel pain, also have headache, occipital headache. So this region, the headache will be there. When you palpate the suboccipital muscle, patient will tell, yes, I'm getting a headache here. And the subject will be doing a sitting job, office clerk, who is always prone for hamstring tightness also. So that is why it's important to treat these muscles together. And we need to get the clue from history. If a subject is having a sitting job and his posture, knee is flexion, so definitely hamstrings can become short. And his posture in the neck, which is a forward head posture, accompanies the knee flexion, both together. And we know that they both are anatomical chain. So they will become tight together. Because we use them or abuse them or overuse them together, they go for dysfunction together. So that is why myofascial chain dysfunctions are more important to evaluate than just muscle palpation, muscle testing, or joint testing, joint treatments versus nerve testing, nerve treatments. It's important to see muscles as a chain. So one is the anatomical chain. The second type is the physiological chain. Physiological chain comes either because of the nerve that supplies these muscles. Because you know physiology means conduction, metabolism, circulation. So blood supply, an artery supplying multiple muscles, all the muscles will be physiological chain. Because if that blood supply affected, all muscles go for ischemia. And the same way, if these muscles are affected, they affect the vein also, which is draining into the single vein, common vein for particular muscles. Nerve also, all muscles supplied by sciatic nerve. It's a physiological chain. Whereas dorsiflexors form, the dorsiflexors actually are part of the anterior chain or the front line. Plantar flexors are the posterior chain. That is anatomical. But physiologically, both of them are sciatic chain, the sciatic nerve. Because dorsiflexors are supplied by deep peroneal nerve. Aortars are supplied by the superficial peroneal nerve. Both are common peroneal. And the posterior compartment is supplied by the tibial nerve. Both tibial and common peroneal is actually the sciatic nerve. So understand the difference between a physiological chain versus an anatomical chain. Most of the times in literature, globally, they emphasize only the anatomical chain. But in AOMPT, we emphasize physiological chain because athletes or normal individuals will always have nerve injury which can affect multiple muscles and also vascular insufficiency that can affect multiple muscles. So ensure to differentiate between anatomical chains, physiological chains. And the third category is the biomechanical chains or the functional chains. So anatomical, which is layer wise, physiological, which is neurovascular, common muscles supplied by the nerve and the blood vessels. The third is the biomechanical or the functional. Remember, what is functional? If I am talking to you, there are some muscles which are working that are producing the movements. They are called as mobilizers. Whereas other muscles are working for my posture, the stability. They are called as stabilizers. Stabilizers, they work first and then later the mobilizers work. If I have to use my hand, my core muscles are stabilizers, my scapular stabilizers, my rotator cuff stabilizer, elbow also stabilizer. Only the hand is working with mobilizers. So understand that proximal stability, distal mobility, the principle of proprioceptive neuromuscular facilitation, PNF. Same way, functional classification of muscles is stabilizers, and mobilizers. Right? So what is the characteristic of these muscles? Stabilizer muscles are oxidative. They have the oxidative enzymes and they can work for long periods of time. They are for endurance. Mobilizer muscles are glycolytic. They are anaerobic. They are fatigue prone. And they actually have white fibers. You would have heard about the red fibers and white fibers. Red is the oxidative. White is the glycolytic. Fast twitch and slow twitch. Fast twitch for the white or the mobilizers. They have more fast twitch fibers. Slow twitch is for the endurance and for the stabilizers or the red fibers. This functional classification of muscles make us to understand that if I am standing, my soleus muscle, my quadriceps muscle, my gluteus medius and minimus, my transversus abdominis, my multifidus, my diaphragm, my pelvic floor, and of course the deep cervical short flexors all work together. And when I'm using my arms, it is the scapular middle trapezius, rotator cuff, subscapularis, supraspinatus, infraspinatus, and teres minor. So it's important that all these stabilizers get that firing and they maintain my posture when the mobilizers can move my arm. Even the masticatory muscles are mobilizers. My tongue muscles for speech, they are mobilizers because for articulation. So various muscles have this functional role, stabilizers and mobilizers. So we need to see myofascial chains as part of anatomical chains, physiological chains, and biomechanical or the functional chains. And functional activities are even performed by these muscles together. So what happens in the anterior as I rotate the model? Okay. I want you to focus on the model. Right. So we have a red tape and a blue tape. The red is the deep anterior or the deep front line. The blue is the superficial front line. And it goes all the way up till the head. So it goes from the muscles. Remember, the red one, the deep front line, includes the visceral fascia. What are the visceral fascia? Pelvic floor, peritoneum, diaphragm, pericardium, which is here. Okay, pericardium. And then it goes to the sternocleidomastoid, where the anterior group, the scalenes, which are here, and the masticatory muscles, the masseter, temporalis, medial pterygoid, and lateral pterygoid. So that is the red deep front line or the anterior superficial myofascial chain. Next, we have the blue, that is the superficial. Pardon me, the red one is the deep. Okay. The blue one is a superficial one. It includes inverters, which is the tibialis anterior. And then it goes to the patella and the patellar tendon, the superficial chain, quadriceps. Then it goes all the way to the rectus abdominis. Okay, the blue one, right in front of the body. Whereas the red one in the hip, it is for the iliopsoas. So iliopsoas is deeper. So that goes as the deep front line. Whereas the quadriceps, it is the superficial in the thigh. That comes as the superficial front line. Pardon. So when it goes all the way up, you can see that it is going both the sides for the pectoralis major. And then it comes to the sternocleidomastoid. That is the superficial front line. So I repeat the superficial front line from inverters to the quadriceps or the extensor expansion. After quadriceps is the rectus abdominis, and rectus abdominis, pectoralis major, then sternocleidomastoid. That is superficial. Whereas the red, that is deeper, is for the other dorsiflexors with You can see for adductors in the thigh, and then the iliopsoas at the hip, and it goes to pelvic floor, then diaphragm, and it goes peritoneum, the visceral fascia of the abdomen, diaphragm, then pericardium, which is behind the sternum, and then we have the scalenii muscles and masticatory muscles. So that is the deep front line. Understand that you need to sometimes memorize because this is anatomical chains. And you will find among this in the anterior group, a quadriceps weakness, patient can have dorsiflexors weakness. Patient with foot drop will be having quadriceps weakness. So to get the best activity of dorsiflexors, you have to activate the quadriceps. And the same way, people with the pelvic floor dysfunctions, either sexual, urinary, or reproductive symptoms, will have adductors, tightness, or overactivity. Because that is the deep front line. And the same way, the peritoneum, diaphragm, pericardium, the abdomen, diaphragm, and pericardium, that visceral fascia is also directly interconnected. And because dysfunction of the diaphragm, patients work the scalenii muscles. Scalenii and the diaphragm are part of the deep front line. So we release the scalenii, but treatment will not be complete unless you activate the diaphragm. So that is where we are treating the front line. So would Professor Arsyad or Professor Waliyu like to summarize and give a perspective about the myofascial chains, the three types, and of course, the lateral line, back line, and the front lines in the body, the importance of myofascial chains in sports and also in manual manipulative therapy. Before we move on, I would like to appreciate the teamwork collaborated by, and of course, the sponsors, the Uni Health, and the collaborators, the Padma Kumara Foundation, and the Manav Rachna International University Academy of Orthopedic Manual Physical Therapists, AOMPT, is honored to collaborate with like-minded people for a better world. Because when physical therapists become better, they will ensure that the world automatically becomes better. Every person needs physical therapy, whoever is alive. So wishing good luck to all the physical therapists of Indonesia and also the faculty members of Padma Kumara Foundation for their teamwork, and wishing you all the happiest of the new year 2023. Stay the best and never stop learning. Good luck to you all. Professor Khanna sir, can you suggest some inputs of after attending my presentation? If you can. Professor Khanna sir. Okay. Shall I request our Ritu ma'am to summarize? The president of the AOMPT, madam, will provide a short summary. Yes, ma'am.
Yes, sir. I would like to add in this that understanding of myofascial chain according to your explanation, how the anatomical relation between that muscles, which are as a anatomical, we see that muscles that goes in the same time in the dysfunction. So because they are born together, so they will go in the function and the dysfunction together. So if we talk about the physiological, so where the metabolism, circulation, and the conduction affect that particular chain itself, either the lateral chain or the superficial or the deep chain, it can be affected by the physiological effect of one muscle to another muscle also. And in the functional chain, yes, as a sports person or whatever the activity we do, so one muscle can affect the functioning or of other muscle also. Like you were explaining how the tightness of that particular calf muscle of one side can affect the contralateral side upper limb activity, either the whatever the work we are doing, the throwing activity or the sports activity, the table, the badminton activity, and whatever the activity which in this the chain affect from contralateral side, that can also be possible. Because we see that sometimes the patient is having with the knee dysfunction, the patellofemoral pain in a one side of the knee, right side, and the lateral side they feel the pain in their shoulder also. So it means there is a correlation between, we see that it happens. And the patient who is having a frozen shoulder, they feel the tightness in the contralateral side of their knee also, and sometimes they feel the tightness in their hamstring also. So it means that oblique chain, that is also from the back line, the functional line, the or the superior, and as well as the deep line, where the visceral part also plays a very major role. Sometimes the patient is having a dysfunction in the pelvic floor. Yes, that is the deep myofascial chain which is passing through that pelvic diaphragm, can affect the patient's activity of their shoulder activity also. And sometimes the diaphragm weakness of that patient can affect their lower limb activity also. It means there is a relation because of these chain plays a very major role. Or one activity, one muscle activity influence the other activity also. Because as a part of the myokinetic chain, we see that the stabilizer and the mobilizers which affect the activity of each other. Sometimes stabilizer influence the other stabilizer also. Like when we treat the pelvic diaphragm, that time the patient improve their breathing pattern also with the stability of the diaphragm, because here the both are the stabilizer, the diaphragm and the pelvic floor, so they affect. Or sometimes the patient is having a pain in the neck muscle, the upper trapezius is having a trigger point. So if we treat the stabilizer, we give the stability to the mandible stabilizer, we treat as a deep cervical flexors training, so they can improve the activity of that particular elevation of the limb also. So these are the things which we can see that it is completely a correlation between stabilizer to stabilizer, stabilizer to mobilizer. So they can, the stabilizer can inhibit the mobilizer activity also, or stabilizer can influence the activity of other stabilizers also, because of these myokinetic chain. So for that, the myokinetic therapy is also a very useful treatment, the way of treatment where we can treat the one area, the patient get the effect on the other area also. So this is the way, as a frontline chain, back line, either the superficial, deep, or the functional line, the back line which is functional, so they can affect each other. So I think it is very important to understand by taking the history of the patient, that what type of either there is a history of any calf muscle tightness, or either the history of the frozen shoulder from last 4 and 5 years back. After that, they are having a pain in their knee also. So this is, we can correlate by taking the history. Or the patient is having a tension like headache, and when we take the history, they say that from last 5 years back, I was in the plantar heel pain. So it means there is a relation between that the kinetic chain of that particular functional chain. So it means that plantar heel affecting the suboccipital occipital muscle also. So we can treat that, how we can give our treatment by taking the history, by doing the proper evaluation, either their injury. After that, we can correlate that it can be the cause. What is the primary? Either the calf muscle tightness was the primary, or the frozen shoulder was the primary. According to that, we can see what we are going to understand about the chain, which chain is influencing, either the superficial chain, either the deep chain, or either the patient is having some visceral problem, they went for any surgery, after that they are having these type of pain. So we can evaluate by taking the history also. So for that, it is important to understand by these meridians understanding of either the functional, anatomical, and as well as the physiological, then we can correlate the patient dysfunction. So this was the way you have explained, and already we know that how whenever you explain in a very simple way, anyone can understand that what you were saying, because with the model you were showing that how these chains are going from foot to head, you have shown. So it is very easy, and I can surely say that the participant who all are sitting here now, they can easily understand that what are the myofascial chains in the front, back, and as well as the lateral chain, how it affects. So thank you so much, sir. And really, it was a very comprehensive explanation from your side. So thank you, sir. Yes, sir.
Professor Valuyo, Imam sir.
I'm thinking that your idea, so the myofascial change is important for the manual manipulative, because all of the, if we have a problem in the neck, so sometimes we have related with the ankle, calf, and so on, as you were mentioned. And also it is important how to prevent the condition to not repeat again the injury. So it is my opinion. I'm thinking that also we have a question for Dr. Kana, Professor Kana, but it's related with you also. So please give an answer to the question from the Cairo Anwar Bekasi. The question are, first, if a sportsman have, we know that sportsmen have a risk to get injury. So how to avoid injury? There are specific method for increased human body and fitness. The second is, what is a method of a therapy for this injury? And the third, what is the manual therapy using for this injury for the sportsman? Okay, this is a question from the Cairo Anwar Bekasi. So please, Professor Kana said to me by WhatsApp that he is have a Bekasi. So please you give answers, Professor Senthil.
Just a moment. Because the question is on sports, I hope the participant has asked the question in Bahasa Indonesian in the Zoom chat. The basic problem for the participant is understanding of the English. Because in my presentation, I talked about athletes, sports injuries, and I also spoke about how to train the muscles. This is the biological component, what physically what we can treat for the athlete. But nutrition, like products of UniHealth, supplements, they are all very important for physiological metabolism. Depending on the athlete who is a sprinter or a marathon runner, their diet has to be individualized. So that is very important, the physiological aspect. And then the psychological aspect. So there are 3 P's, PPP, P for physical, P for physiological, and P for psychological. This psychological factor is a very, very important factor in athletes. Many sports persons feel until they get the pain, they have never done the adequate training in an exercise. So that keeps them at risk for injuries. So it's a combined team effort People like Professor G.L. Khanna is a sports medicine physician, doctor, whereas we are physical therapists. There may be even coaches and trainers and even massage therapists, dietitians. Multidisciplinary role is there. Everybody will contribute in order to ensure that that particular athlete has to get the best combination. It's not one single magic treatments.
Okay.
Nothing can prevent anything. But we can ensure that the conditioning of the athlete is improved so that for that particular game and their schedule throughout, their best performance they are able to do and give for the country. So remember, it is to do with a lot of factors like even personal habits. If the athlete does a smoking, he does an alcohol, they use a doping agent, even biological doping agents. So many have an effect. And even some of them have tattoos on the body. The tattoos affect the blood. The chemical composition of blood is disturbed. So a lot of factors will affect the metabolism and it will in turn reflect in the sports performance. So do not think that I will do one technique and then it will prevent the injury. I will do taping, it will prevent the injury. No. It's a combination of biopsychosocial. Women athletes, they are at risk for injury because of hormonal imbalances. Their monthly menstrual cycle. If they are after children, postpartum, or they are postmenopausal, menopause, that comes at 45, 50 years. So women have a different health issues and risk factors for sports injuries compared to men. That is why social factors are important. Psychological factors are important and biological factors are important. Combination of all this and multidisciplinary only can prevent a sports injury. Risk factors, what is identified? I, as a physical therapist, I will identify the physical risk factors. But a physician will identify the physiological risk factors. Whereas a psychologist, a sports psychologist, will screen for psychological risk factors. So I can treat the physical part, physician treats the physiological part, and the psychologist treats the psychological part. Even all this, we cannot guarantee a prevention of injury because at that game situation, the athlete can push themselves beyond the limit, which might lead to an injury. You work your best, automatically the outcome will be better if it's a combined effort. If you think about outcome, it will be a failure. Think about the procedure process. Concentrate on upgrading your skill. Do you know the treatment techniques? Are you trained by best teachers, best academies, best universities? Because your treatment technique skill is important. Taping cannot prevent injury. How you do the taping, that is important. So, right from knowledge upgradation to the biopsychosocial, multidisciplinary role. Because sports person is not a single patient who is walking into your clinic. Sports persons, they are in the team, they are in the ground, on the field, and they are under the care of multiple professionals throughout their year, the career. So understand this role, and I hope this question has come because there was no translation. If the translation or summary in Bahasa Indonesian is given, my presentation, automatically I concentrated on these contents to explain the biological perspective from muscles. because the topic is myofascial chain, not the joint capsule ligament injuries or the nerve injuries. To understand that your scope of widening your knowledge is the first step to upgrade yourself so that you can prevent the injuries of the sports persons by sound decision making.